now we're going to discuss the wide world of abdominal pain as a chief complaint. Some of the things we're going to talk about are what makes abdominal pain such a high-risk chief complaint. The basic answer is because there's a lot of stuff in there that could be causing the problem and the pain, so we really need to be diligent in our assessment to have the best differential diagnosis possible. That way, we can determine which category it falls into: critical, potential life-threatening, or non-life-threatening. We're also going to discuss common pitfalls when dealing with patients with abdominal pain, so just maintain that high index of suspicion. As stated earlier, the reason that this is considered such a high-risk chief complaint is because it's one of the most frequent complaints that we receive in EMS, but also the most challenging because it could range from something simple as food poisoning all the way to a AAA. One is obviously way more deadly than the other. However, if we do not ask the right questions or gather a thorough history from the patient, we won't be able to determine which is which. For example, a patient that has a history of hypertension that stopped taking their meds and is complaining of a tearing pain in their abdomen, I'd have a higher index of suspicion of a AAA. Conversely, if they just said that they got some sushi from the gas station on sale and they have no history, I'd be leaning more towards the food poisoning route. The timeline of the discomfort is also part of the history that will help your assessment. Sudden, sharp abdominal pain could be a more serious condition than someone who battles with chronic abdominal pain and has a history of irritable bowel syndrome. However, can we truly rule anything out? We can only narrow down our differential diagnosis and maintain the ABCs and attempt to assist in comforting them. So, from looking at this list on the slide, you can see that there is a whole array of causes of what could be the cause of the pain, and this is only a partial list. Some of the causes require immediate surgical intervention due to the immediate life threats like ectopic pregnancy or aortic dissection, while some other have a higher surgical urgency like appendicitis or diverticulitis, while others do not require surgery like gastroenteritis or IBS. Again, being a thorough clinician is the key to success when treating these patients. The three types of pain that we may encounter when dealing with a patient with a chief complaint of abdominal pain. First, we have visceral pain. Fibers on the walls of the hollow organs and capsules of solid organs begin to stretch or distend, and also from excessive contraction causing the pain. It is a pain that's poorly localized, usually in the middle of the abdomen, and described as dull or achy. This is because visceral pain fibers originate on both sides of the spinal column, which is why it's not well localized. Second, we have somatic pain. This is caused by irritation of the parietal perineum. These fibers travel to a specific level of the spinal cord, which in turn makes the pain more localized. These patients will have tenderness upon palpation, guarding, and rebound tenderness. Your patients will describe the pain as sharp, intense, in very specific location. As a side note, most abdominal pain often begins as visceral pain and then progresses to somatic pain as the inflammation spreads, which is why getting a length of time of the discomfort is important. An example of this patient might be complaining of epigastric pain, which evolves to severe right upper quadrant pain due to cholecystitis. Lastly, the patient may be experiencing referred pain, which we all know is a pain that's perceived at a site that's different than the affected organ. This is caused because of overlapping nerve transmission pathways at the level of the spinal cord. Kind of like how major highways would grow, we would begin to build overpasses so that it decreases the amount of traffic. Unfortunately, our bodies only have so much room in them, and some of the pathways are shared. An example of this is when a diaphragm is irritated from free air or blood, the patient may have a complaint of shoulder pain. Our clinical presentation of the patient is going to be hand in hand with our secondary assessment of gathering vital signs and physical examination of the patient. Obviously, patients that are experiencing any type of pain are going to have similar vital signs: elevated blood pressure, pulse rate, respiratory rate. Some things to look for that might present differently are whether fever is present, confusion, and skin color and condition. Knowing where the organs are located is also very important, so when we go through the motions of palpating all four quadrants, we're actually able to know what we're feeling and what organs might be involved in the discomfort. The elderly. Now, I know some of you might get offended when I say the number, but this is what the book says, but that number is 60. Of patients older than the age of 60 who present to the emergency room with abdominal pain, nearly 60% are admitted. 18 go directly to the operating room and have invasive procedure, and 5% die within 2 weeks of presentation. Now granted, most of the elderly do have comorbidities that can confuse the clinical situation, making obtaining an adequate history more difficult. They may have a reduction of pain due to some physical complications, which decreases the typical response of pain or infection. The risk of mortality in patients presenting with abdominal pain increases with each decade of life. So as a clinical suspicion for a serious disease must be higher in the elderly patients. The elderly also have a higher pain tolerance, so they will more likely attempt to downplay the discomfort that they are experiencing. So maintain your high index of suspicion, narrow your differential diagnosis, and transport the patient. So after we've done our primary assessment and established that there are no immediate life threats, we complete our secondary assessment, which includes the vital signs, history taking, and our physical exam. When it comes to the abdominal pain and complaints, the OPQRST is going to be a good compass to determine the direction of your differential diagnosis. So be sure to ask the right questions in the right way. There have been multiple times when we have seen the new guy begin their assessment and they ask where the pain is, and the patient just responds, "My stomach." Then the patient follows that up with, "It just hurts." To narrow down the location, try to ask the patient to physically point to the location that they are experiencing the pain. That way you have a better idea. Then you can follow that up with, "Can you describe it to me? Is it like a nerve pain, stabbing, achy, dull, pressure? What exactly is it? There are so many different kinds of hurt. I want to know exactly what you're experiencing." That does two things. It gets more information you need, and it builds empathy, which creates more of a chance that the patient will be truthful with you, and that only helps your differential diagnosis. So make sure you complete a thorough history on these patients. That way you can be as accurate as possible by asking the right questions. Now, the stuff that we all know and should be doing on every call: the history, signs and symptoms, allergies, what medication do they take, and what's their past medical history. Did they eat something that didn't agree with them? Risk factors is a factor in the abdominal pain category, because if someone has a history of pancreatitis and they were out drinking with his buddies, that could probably be a contributing factor to the discomfort. Now let's get to the immediate life threats. Our job is to rule out the immediate life threats causing the abdominal pain, such as a AAA. AAAs are commonly misdiagnosed. 1/2 of all AAAs are misdiagnosed on their initial presentation. The things we need to look out for are complaints about abdominal, lower back, or flank pain that is extremely nonspecific. So when we respond to calls for abdominal pain, that is going to rule out the patient that is asymptomatic, because they wouldn't be calling EMS if they weren't having a complaint, you would hope. The patient is symptomatic can sometimes be a complaint or of something other than the abdominal pain. Examples of that would be like swelling in the legs from compression, worsening hypertension, but more common complaints are a mass in the abdomen or a back pain. Lastly, a ruptured AAA, which is not good at all. This presentation has classical triad of back pain, hypotension, and a pulsating abdominal mass. Only about 1/2 of patients who survive to reach the emergency department manifest all three findings. Most patients have no prior knowledge of their aneurysm, which is why it's such a high-risk chief complaint. This can have the potential to have a catastrophic outcome. So be on the lookout for the complaints that have hypotension, severe back pain, or abdominal pain, and maintain that high index of suspicion. There's nothing we can do to rule out this complaint in the field. Here are some visual aids to help show you what's going on inside your body with the AAA. Normal, not normal, and really, really bad. How are we going to come to a differential diagnosis of a possible AAA? Well, we start at the top. We get the call notes, we make patient contact. "Hello sir, what seems to be the problem?" We knocked out our A, B, C, D, E. So he's talking, his airway's open, he's breathing, circulation, feel for the pulse, alert. Same thing we do on every call. He tells you, "My stomach's really killing me and I get dizzy when I stand up." Ding, ding, ding. Those should be red flags for you for a couple of things, right? MI, heart valve problem, low blood sugar, AAA. So we continue to gather more information about facts, our vital signs, to help narrow down that differential diagnosis. The patient has a low BP. Your assessment finds a pulsating mass in his abdomen and no medical history. 12 lead is unremarkable. Where's our index of suspicion pointing? Bingo, AAA. With what our findings are is how we determine how we are going to treat. Sometimes we can make the complaint better, or sometimes there isn't much we can do. But like a AAA, our main concern and main focus should be not to delay transport or make things worse for the patient. Alright, ectopic pregnancies. Did you know that the frequency of ectopic pregnancies has increased 5-fold since 1970? About 2% of all pregnancies in the United States will be ectopic. Now, what exactly is an ectopic pregnancy? Here's the textbook definition over to your side. Basically, any time that a fertilized egg implants or attaches somewhere other than where it's supposed to. 80% of ectopic pregnancies occur in the lateral 2/3 of the fallopian tube, which is the closest to the ovary. 15% occur in the medial portion of the tube, and the other possible places are in the abdomen, ovary, cornual, and cervical. Each of those are very rare, however. Starting with our systematic approach, we want to think about what the patient is telling us and their complaint, so we have a broad initial differential diagnosis. The three main ones that we're looking at for ectopic pregnancies are amenorrhea, vaginal bleeding, and abdominal pain. Amenorrhea is just a $5 word meaning that the patient hasn't been menstruating. Of these complaints, 97% of patients have had abdominal pain. They will complain of tenderness upon palpation. Handling patients that are women of childbearing age who presents with signs of hemorrhagic shock without historical or physical evidence of trauma should be considered to have an ectopic pregnancy until proven otherwise. Keep in mind, we cannot reverse this issue. Our job is to identify and address any immediate life threats and transport to the closest appropriate receiving facility. Pain is usually going to be severe in these patients, so consider pain management early. Continually reassess these patients to look for signs of hemorrhagic shock and treat accordingly. Our goal is to initiate transport if you suspect an ectopic pregnancy. Repeat vitals every 5 minutes to establish trending. Alright, now let's talk about acute appendicitis. Here's the definition. Lots of big words, but to break it down, let's look at where it is. It's located right in the lower right quadrant of the abdomen, and it's about the size of your pinky finger. Now, let's talk about what it does. Does anybody out there know what the appendix does in the body? Good, that's right, no one knows. Lots of people have theories like its purpose over time. We've maintained it as a vestibular organ, but it's also been said that it's a storage for good bacteria. But ultimately, we don't know what it does, and it doesn't matter once it gets inflamed. This is a serious condition because if it does rupture, that's going to cause the spread of the bacteria throughout the whole entire body, and we don't want that. So what are we looking for? The most reliable signs of acute appendicitis is right lower quadrant pain. That is present in 100% of patients suffering from appendicitis. They may also have some nausea and vomiting, but be sure to ask the right questions and listen for the answers. Look at this. Our goal of care are similar to the previous complaints that we discussed. Pain management. Treat immediate life threats and transport quickly to the most appropriate facility and maintain that high index of suspicion. Moving on. Mesenteric Ischemia. What in the world is that? Well, here's the definition for what it is. This is a blockage of blood flow to the small or large intestine. So what do we know? We know that time is tissue. Whether it's a stroke patient or if it's a heart attack, we need to start perfusing the patient. And that's what is going on with this patient. They have decreased perfusion for some reason that is causing cellular death to the small or large intestine. 50% of acute mesenteric ischemia is caused by an embolism from the heart or a proximal artery source. As we just mentioned, the embolism is going to be the major cause of the issue. The other causes could be from something similar to a DVT, and it's called an MVT, a mesenteric venous thrombosis. We deal with DVTs so much more frequently. They involve pain, redness, and heat to the site. We won't be able to feel or see anything. However, the pain in the patient describing to you is the cause of a higher index of suspicion, especially if it's accompanied by a fever. Again, When we are completing our assessment of the patient, we are listening and looking for things that stick out to us, the signs and symptoms that they are presenting with. Looking for abdominal distension, pain, and fever should be red flags to you as a clinician. Mesenteric Ischemia is an uncommon clinical entity with a very high mortality rate, and non-specific clinical findings making the diagnosis very difficult. Symptoms have a wide range for people who have this condition, so don't rule it all out. Again, all of these possible diagnoses fall under a very broad category of abdominal pain, and our goal is not to make an exact diagnosis. We can't. We don't have the tools, and there's a lot of stuff going on in that part of the body. So knowing what it could be helps us be better at taking care of the patient and making them more comfortable and possibly saving their life instead of just getting a refusal when we know it could be something more serious than just a tummy ache. So let's just review one more time. How do we narrow down our differential diagnosis to have a better idea if it's life-threatening or not? We do the same thing the same way each time so we don't miss anything using the systematic approach. We start with the call notes, meet the patient, gain our cardinal presentation, perform our primary assessment, treat any immediate life threats if they present, move on to our secondary assessment, which will help us narrow and navigate down our differential diagnosis. Using our diagnostics, such as vital signs, 12 lead, and so on, a good history, and OPQRST, and follow that up with a detailed head-to-toe exam. Trust in the approach and know what you are looking for. The systematic approach will take you to the answer that you are looking for. Some of the things that we want to stay away from, the pitfalls, are pretty common sense. Failing to obtain a complete history, which won't happen with the systematic approach. Not having a high index of suspicion for females having an ectopic pregnancy. No fever, no infection. Not telling the ED you gave pain meds. Like I said, stuff we already do. Keep in mind our job is to rule out based on the information that we are given and use the diagnostics to make a best guess. Our job can be like playing the Wheel of Fortune. All we have to do is fill in the blanks and do what is best for the patient based off of that. Keep up the good work, everyone, and if you like this video, hit subscribe button in the bottom corner and be sure to like this video.